Good afternoon, everybody. Hello. Welcome to the next installment of the Timothy A. Johnson Medical Scholar Series. Many of you who have been here before know we like to mention and remember Dr. Johnson, in whose name this program, for who this program is named and whose honor it is. Dr. Johnson was one of the founding faculty members of the Virginia Tech Carilion School of Medicine. He was a basic scientist who worked in cardiovascular research and had a great interest in the interface and translation from fundamental science to translational and clinical science, and I'm sure would have been delighted with today's speaker as many other speakers in the program. So it's always great to remember Tim when we start this seminar program. So it's my great pleasure to introduce today's speaker, Dr. Jeff Kline from Indiana University School of Medicine, where he is professor of emergency medicine. Dr. Kline did his undergraduate degree right down the road. He's a Hokie at Virginia Tech. Glad to always have a Hokie back. Studied biochemistry, I believe, as an undergraduate, and then went on to his medical degree in Richmond at then MCV, VCU. I'm not sure, was it MCV when you got your degree? Medical College of Virginia. And from there went on to do his residency in emergency medicine, Carolinas Medical Center, where he also stayed on to do a research fellowship in emergency medicine as well. He is very involved with the American College of Emergency Physicians. He's won their Established Investigator Award. The Society for Academic Emergency Medicine has also bestowed upon him their Excellence in Research Award. The American College of Emergency Physicians has given him the award for outstanding contributions to research in emergency medicine. He is patented, has quite a few patents, somewhere between 15 and 20 or perhaps more at this point. He serves on the editorial boards of a number of key journals in the field, including as the editor-in-chief of Academic Emergency Medicine and also as editor-in-chief of Academic Emergency Medicine Education and Training. He is clearly recognized as, if not the world's expert and leader, or certainly amongst them, I would say on pulmonary embolism, an area that many of you will be dealing with, of course, in your clinical careers and realize the clinical importance of that. But in addition to his many contributions in the clinic where he's actively involved, he is clearly an established and highly recognized innovative researcher who has continued to change the field in emergency medicine of how care is delivered and using very systematic approaches, developing algorithms, using Bayesian approaches and algorithms to come up with ways to evaluate, exclude, or include diagnoses of things like pulmonary embolism, for example. He has over 240 or 250 peer-reviewed publications in the field, which goes to show you can be a world-class physician and a world-class scientist at the same time and be contributing heavily to both. So he's a great role model, I think, for many of you medical students in the room. Dr. Kline has studied early on myocardial metabolism effects of insulin during verapamil toxicity and the diabetogenic effects of verapamil poisoning. Has a whole series of papers and studies in that, but been very important for treatment. He studied the clinical features of acute pulmonary embolism. As I mentioned already, has applied neural network analysis to detect pulmonary embolism. Also Bayesian network models for predicting things like venous thromboembolism, and has gotten into a deeper understanding mechanistically of cardiac inflammation and right ventricular dysfunction after pulmonary embolisms as well. And we're going to hear a bit today, I think, about cyclic G, maybe it changed a little bit. No, there it is, cyclic G signaling pathway and the whole patient approach to treating patients with acute pulmonary embolism. So please join me in welcoming Dr. Jeff Kline.
What a fantastic introduction and a lot of work to put that together, so I thank you. And this is a talk about 20 years of career, and so I want to go through a little bit about the patient approach and why I'm interested in this pathway, putting myself in the position of the patient that is receiving news that he or she has a pulmonary embolism. Here's my conflicts of interest. So I've got a couple of goals. Is I want to explicitly just teach a little bit about PE pathophysiology, because I thought most of the group was going to be medical students and graduate students. So we'll talk a little bit about pathophys. And I'm just going to explain why I think the nitric oxide guanylate cyclase cyclic GMP pathway may help patients with PE. And then I have an implicit goal just to show some of the options to be a clinician researcher in the field of emergency care. I'm not here to proselytize, but I just want you to see some of the options. So let's talk about pulmonary embolism. It is a common disease. Almost everybody knows somebody who's had a blood clot in the leg or the lung. And this is simply thrombotic material, clots that clog off the pulmonary arteries. About 200,000 people get a new diagnosis of PE each year, and probably about 1 million people are walking around in the United States who have ever had a diagnosis of pulmonary embolism. In the first month after diagnosis, about 10% of people die. And then the area that I'm going to talk about is the fact that about 1/3 of people go on and have this problem of chronic shortness of breath, exercise intolerance, and it's what I call mom just ain't right. It's also dad just ain't quite right. You know, it's the people that just can't get back to work. There's two sort of varieties of that. One is chronic thromboembolic disease, and these are clots that remain in the lungs, and the lungs don't work right and the heart doesn't work right, but probably mostly with exercise and exertion. And they can't work through a full day and they lose their jobs. And then there's CTEPH, which is almost like cancer. That's when you get these occlusions in the lung and you develop pulmonary hypertension. And Dr. Aziz puts a catheter inside of your right heart and up into your pulmonary artery and measures a mean pulmonary artery pressure that's 35 or higher. So CTED is like pre-CTEPH, and both of them mess people up. Here's the acute pathophysiology of PE, and that's just a cork. Not hard to understand. A clot goes into the lung, and it backs up blood flow, and the right heart gets stressed. But there's also this effect where all these chemicals get stirred up as a result of the clot lodging in the lung. And those chemical mediators cause vasoconstriction in the pulmonary vasculature. And they're mediated by multiple different things. Some of them come out of the clot, some come out of the lung, some come out of platelets. And there's also the effect of the blood getting churned up that I've shown here in this little white arrow that's tortuous. The blood gets churned up, causes hemolysis, releases the contents of red blood cells, which are bad news in the lung because they scavenge nitric oxide, the principal vasodilator of the lung, and cause vasospasm. And so this is an example, let's see if we can make this guy play, of right heart strain that's acute. This is on echocardiography, and you can see the right heart there and the upper part of the panel. You see how big and dilated it is, and it's Damon, what's it called? What's the shape of the heart?
D.
It's a D-shaped heart. D-shaped heart. Both of them are D-shaped, the right and the left. And if you look in there in this little echo, do you see something flipping around? That little echogenic thing right there right there in the right heart. That's a clot that's in there. So this is evidence of right heart strain on transthoracic echocardiogram. Now this thing is what's called a perfusion lung scan. That's when you inject some radioisotope into the bloodstream and then take a gamma counter and look and see where the radioisotope goes in the lung. You can both breathe it in, which are the top images, and also inject it, and it's the perfusion part. Now look at those perfusion scans, which are the two lower rows, and see how it's eaten up, it's chopped up. That's clots in the lung that remain. This is the basic pathophysiology of CTED, CTEPH, where you continue to have these obstructions and they don't go away, and then they start doing bad things. It can even produce this. Does anybody want this in their lung? Nope, you don't want that. Looks like a staghorn calculus, like in a kidney almost. This is a nasty thing that grows inside of the lung, almost like a cancer, and obstructs blood flow and causes misery. This is full CTEPH. But most people with CTED have inducible pulmonary hypertension. This is a study that I did of 200 patients that we studied across time. We did an echo at baseline at the time of diagnosis of PE, and then we did an echo 6 months later. And these were all patients that had what's called submassive PE. They weren't the really, really severe ones. We brought them back, did all kinds of tests on them, including walking tests and some function of life tests. But this echo shows with the red lines that a number of patients had almost no measurable what's called tricuspid regurgitation. That's blood flow going in the wrong direction in the right heart at baseline, and that's down there at diagnosis. Whereas we brought them back 6 months later, and a big chunk of them, about 1/3, now have a bunch of what's called TR and evidence of pulmonary hypertension. And this is getting usual treatment. So there's a fraction, about 1/3 of patients that go on and get worse despite what we're doing to treat them, and it makes their lives unhappy. So what do I mean by this whole patient approach? So this is a little bit granola, and it has some of my background of what my mom taught me, who is right here in the front row, by the way, and that is about thinking about people as a whole unit and understanding things from their point of view. And I also learned this from Dr. Ed Spencer, who is here, who was my residency, housing and residency life director when I was at Virginia Tech and was an undergraduate resident advisor and head RA. So some of what I'm talking about here comes from that human experience that I grew up with. And that's the combination of knowing the disease and knowing the patients that it affects and seeing it from their point of view. Now, what's our current treatment? It's blood thinners, anticoagulants, and fibrinolytic agents that dissolve the blood clots. But the risk of these things is bleeding. It's bleeding in the brain. And we don't really know what the exact percentage is going to be for any given patient, but it's not zero. It might be as high as 5%. So imagine that it's your mom or dad or you with a blood clot in your lung, and a doctor comes along and says, we'd like to get rid of this blood clot in your lung, and you might have about a 1 to 5% risk of having bleeding in your brain. Well, that scares the heck out of patients, as shown by this work here done by Kirsten Hogg, who worked with my group, and she took a whole bunch of patients, basically asked them a lot of questions using something called the standard gamble theory. What the standard gamble theory is it keeps asking you, how much of your life would you trade off to not have this condition? So like how many years of your life would you trade off to not have your leg chopped off? It's really weird questioning, but it's how you can get to the answer of the value. Look at severe disabling intracranial hemorrhage. Not surprisingly, if you look at this disutility value on the right-hand side, it's almost like 85% of life. Patients fear intracranial hemorrhage. That's the patient-oriented point. That's the whole patient approach to understanding. So there's intracranial hemorrhage, which we live in fear of, but there's the 1/3 that have chronic dyspnea, as shown from this meta-analysis that we're getting ready to publish in Vascular Medicine. Of all the papers that have found 30% of patients post-PE, chronic dyspnea and fatigue, and they can't walk right. They can't do this standard exercise test called the 6-minute walk test, which is a routine index of exercise capacity. Just ask a patient to see how far they can walk in 6 minutes, and they're far below normative values. Part of the reason is that post-PE with this CTEPH syndrome or spectrum is patients start off with pressures that are relatively normal at rest, but when you exercise them with a catheter that's sitting in the right ventricle, when they use cycloergometry, you see the pressures go up abnormally high. It's shown in this famous image from the New England Journal that shows the pressures start out relatively normal but go up too high with exercise. So there's exercise-induced pulmonary hypertension after PE, and that's what I'm after with cyclic guanosine monophosphate signaling. Part of the problem are platelets. Platelets are these blood cells that float around and clot everything off, and they become incredibly activated with PE, as shown in this cartoon diagram, in part because of the fact that they get agitated and shaken up in the right ventricle and in the pulmonary arteries, also causing shear effect on the red cells, rupturing the contents of the red cells, which not only scavenge nitric oxide, but red platelets hate seeing hemoglobin. Free hemoglobin really pisses platelets off, and they start to become activated, and they transform from a happy, quiet little platelet that's causing no problem into what's called a superactivated platelet that starts to release microparticles that increase the risk of clotting. And part of this is the risk of recurrent clots despite current treatment. Despite anticoagulation, the platelet can still cause additional clots. So that's some of the pathophys, and this is work that we've done that I think is relatively unique, where we've taken platelets out of patients with pulmonary embolism, compared them to healthy patients, and we take our platelets and put them in an oxygen consumption chamber. It's called the Ouroboros chamber, and then we do some standard mitochondrial testing on them to see how fast they're using oxygen, and these are intact platelets. And if you just look at routine, these platelets that are using octanoate and glucose, they're jacked up compared to the patients that are healthy. And with leak, we give we treat the platelets with oligomycin. Does anybody remember what oligomycin does? Blocks what? ATP synthesis. So any oxygen consumption that happens with oligomycin on board is uncoupled. It's leak. So it's not supposed to happen, and it's elevated with PE. So there's wasted oxygen consumption with platelets. And then if we then completely uncouple the mitochondria with an uncoupling agent, something called FCCP, that's over on the right-hand side with ETS, you can see these mitochondria really want to take off. So those are unleashed mitochondria, like run with the wind mitochondria, go as fast as you can. And the PE platelets will really go fast. And as a consequence, they make reactive oxygen species, shown in the right-hand graph. Those reactive oxygen species go on and do things that mess up both the pulmonary vasculature and the platelet function. Ultimately, the platelets get sicker and sicker and develop signals of apoptosis. Apoptosis is a Greek word, apoptosis, which means leaves falling. It means things are starting to die. It's pre-death. The signals for that include cytochrome C that's jettisoned out of the mitochondria into the cytosol, shown in the left-hand bar chart, and then a reduction in the BCL protein, shown in the right. And most importantly, in the platelet is something called a nexin binding, shown in the lower bar graph. And nexin binding shows us that the membrane of the platelet is sad. It's now starting to expose phosphatidylserine on the outside where it's not supposed to be. It makes the surface negatively charged, and that's a surface that clotting proteins like to bind to and form more clot. So this is bad. You don't want this if you've got clots in your body. But standard anticoagulation doesn't treat it. Let me show you what apoptosis is. This is platelets on the left from PE patients, and these are platelets on the right that have gotten some thrombin. Platelets get all fired up when you give them thrombin, and that's one of the major stimulants of coagulation, but it also stimulates platelets through something called the PAR receptor. And you can see these little fragments coming off of the platelet. And that's the platelet basically doing its popping. It's undergoing apoptosis. Now let's see if my slide works here. Okay. Yeah, so this is a real slide of patients' platelets under fluorescent microscopy with a fluorophore that tags calcium. And we're going to get thrombin here in just a second. Jonathan's going to add thrombin. Okay, that's the thrombin. And see, they got a little brighter. It turned into like a little bit of hotness. You can see the increase in the calcium concentration. You can visually see that. That's the platelets responding to this thrombin. This is healthy patients. Now, let me show you PE patients to understand what's going on inside. See how they're already fragmented and pseudopoding and sort of flattened out? That's the platelets that are fired up inside of a PE patient. And here in a minute, it's going to flip if it plays all the way through. There. Okay, boom. Pow. Now once the pseudopods form, you can see the platelets starting to just disintegrate and blow apart. And that is the reactivity of platelets inside of a human being with pulmonary embolism compared to a healthy patient. This is something that I want to control. PE increases the platelets. So this is quantitative data from what I just showed you, that if we stimulate platelets with chemicals that fire them up, like thrombin, ADP, and arachidonic acid, you get a much bigger increase in intracellular calcium than you do in healthy patients. And you can also see this on something called thromboelastography. So if you've not been in your third year yet in medical school, you're going to hear about TEG, thromboelastography. So you just take a little dish, a little bowl, and put blood in it, and then put a little stirring rod in it, and the stirring rod stirs around, and you stick some chemicals in there to fire up the clotting system. And the stirring rod is connected to some mechanoreceptors, so the more clotty the blood gets, the more that curve goes up. The bigger that curve is, the wider that separation, the more platelet activity there is. And even in the presence of heparin, patients with PE have an increase in maximum amplitude, so they form more platelet-derived clots, and heparin cannot do anything about that. That's our standard treatment for pulmonary embolism. So here's the summary of platelets. As they're hyperstimulated, they undergo apoptosis, and they clot independent of our standard treatment. Now here are our standard treatment options. The first is so-called thin the blood. I personally don't like that term because we're not thinning the blood, we're just blocking protein action. There's no thinning that happens. But what we most commonly use is heparin or low molecular weight heparin like enoxaparin or Lovenox. And then there's direct acting agents like the Eliquis and Xarelto that you see on the television nowadays. Then there's also fibrinolysis. And that's where we activate the part of the blood system that dissolves blood clots. And that's the one that will get rid of the clot. Anticoagulation just allows your body to naturally get rid of the clot over weeks or months or maybe never in some cases, especially CTED or CTEPH. Lysis helps a little more, but it increases the bleeding risk. So, I've got some experience using lysis. This is a randomized trial that I was the PI on, where we randomized patients with relatively severe PE to get this fibrinolytic, clot-dissolving, or thrombolytic, same word, drug called tenecteplase, which is just a mutant enzyme, mutant version of tissue plasminogen activator, or placebo. And then we looked at how patients did over the next 3 months. And what we found is that if you got tenecteplase, that you were less likely to have dysfunction, more likely to be able to walk, less likely to be short of breath, more likely to be back at work. But here's the trade-off, is the one intracranial hemorrhage. And that happened in a patient that I gave tenecteplase to. And I'm a human being, just like, believe it or not, you be a doctor and a human being. And whenever I would go give this drug to a patient, I didn't know what the patient was getting, and the patient didn't know what the patient was getting. And it was a syringe that was given to me by pharmacy that had basically duct tape around it, so I couldn't even see it, even though it was clear and it looked the same in placebo and it looked the same in tenecteplase. And I would go inject this drug, and I'm telling you, there's nothing like the feeling of, am I giving something that I'm depriving this patient of something really important, this enzyme that can dissolve the blood clot, and I'm going to let him go on and die like that one patient did. That wasn't my patient. I didn't enroll her. Or am I giving a drug that is going to bleed this patient's head? And that's an experience that really sticks with you, because you do it and you're like, man, I might have failed to save this patient, or I might have killed this patient. And now that is the human aspect that drives me to want to study something that has a better therapeutic index, because you never forget when the nurse calls you and says the patient in room 6 is seizing, and you know you did it to them because you filled their head up full of blood and the guy died 6 hours later, and I had to go tell his family that. So, you don't forget that stuff. And this is an even bigger study that was done using tenecteplase versus placebos, 1,000 patients. And I just want to point to this red rectangle to show you that the rate of hemorrhagic strokes, or bleeding in the brain, was 10-fold higher in the tenecteplase to placebo group. So patients are scared of that. I'm scared of that, so I want to look for something better. So here's the rationale for cyclic GMP increase. And that's looking across the axis of nitric oxide to soluble guanylate cyclase to the synthesis of cyclic GMP. And typically, nitric oxide is synthesized in one cell and it diffuses over to another cell. The most classic place is in the endothelial cell, which is the generator cell here, where nitric oxide synthase, or NOS, forms nitric oxide, which diffuses over and then binds to and activates guanylate cyclase, which has 2 subunits. In science, we can't just say subunit 1 or subunit 2 or A and B. We've got to call it alpha and beta. So there's an alpha and beta subunit. Nitric oxide binds to it. You get cyclic GMP, which goes on and does all kinds of things. And the signaling that cyclic GMP does inside the cell that I'm most interested in are, again, in this red box: smooth muscle relaxation in the pulmonary vasculature to attenuate the vasospasm, platelet inhibition for all the reasons I've just shown you, and also cell growth and differentiation, making new blood vessels inside of the lung to overcome those obstructions that I showed you on the VQ scan. This is something we really want to fix. This is a rat heart. It's being perfused on what's called a Langendorf apparatus, and it's tied by its aorta. There's a normal heart on the left, and there's a bad heart on the right. The one on the right has been subjected to plastic beads put into the lung. You got to use plastic beads in a rat because they can crack or lice down clots like crazy. You cannot make a rat keep blood clots in its lung. They're just amazing animals. You can put so much, you can block the fibrinolytic pathway with tranexamic acid. You can do anything you want. You cannot make a rat keep clots in its lungs. So you got to put plastic in the lungs. Otherwise, you won't get any kind of damage. But there is a PE that is about like a moderate PE in a human being. Acute right-sided pressures of 45 to 50 millimeters mercury, and that's what it looks like a day later. And that's what we want to prevent, because that is the etiology in part of mom, dad isn't right, the shortness of breath in the 1/3. So this is the paper that I sent out to review, and this is basically the proof of concept that by attenuating the vasospasm, by activating or stimulating the guanylate cyclase, can overcome that increase in pressure. And this is, look at the left-hand side here, and you can see this RVSP divided by cardiac output. That's a rough indicator of pulmonary vascular resistance to blood flow through the lung. And there's control. And not surprisingly, when we clot up the lungs with plastic beads, a day later the peripheral vascular resistance goes way up. But if we treat with this guanylate cyclase stimulator, we almost can normalize the pressures. This shows how much reserve there is in the pulmonary vasculature that we get to work with. And I don't have to give you a lytic agent and bleed your head. So my summary from 10 years of work with acute studies in rats is that most of the dysfunction comes from right ventricular inflammation, and I showed you that picture of the heart. And it comes in turn from elevated pulmonary arterial pressures. And at least in the rat, it can be prevented by guanylate cyclase stimulation. Now, this work was done prior to any approval or clearance of a guanylate cyclase stimulator. So to go into patients and try to understand whether this is going to benefit, I had to do a trial of inhaled nitric oxide. Nitric oxide's a gas. You can breathe it in. It diffuses through the alveoli, gets to the smooth muscle, vasodilates the smooth muscle. The conceptually nice thing about nitric oxide is fast on, fast off. If you give too much of it, patient gets, say, hypotensive, drops their blood pressure, you stop the medicine and it goes away in a half a second. So it's appealing from the standpoint of some people with PE are kind of unstable, and we don't want to give them a drug that could vasodilate them and drop their blood pressure. So we did this randomized trial called INOPE, inhaled nitric oxide for pulmonary embolism. And I showed my Lewis structure of nitric oxide because, you know, I was a biochem major and always loved chemistry, so you can't get it out of my blood. So the hypothesis was that inhaled nitric oxide plus oxygen would better help the right ventricular function compared to inhaling just oxygen alone in a randomized double-blind placebo-controlled study. And what we had as a primary efficacy outcome was a normal echocardiogram, and I showed you a very abnormal one, at 24 hours after treatment. We wanted to see if we could make the right heart totally normal in people that had pulmonary embolism, and also drive their troponin. That's a blood concentration of a protein that's liberated by the heart that should not be in the blood system, using something called high-precision troponin measurements. So we were trying to improve both of those endpoints, normal echo, normal troponin. And with this study, we hypothesized a 30% improvement, and what I found when I did the study was only an 11% improvement. So, like a lot of clinical trials, this was 10 years worth of work, a $4 million study funded by the NIH. It was, you know, my whole life for really the last 5 years. And it didn't work. It was modest at best. And there's a, you know, little bit of effect here, but if you look at the difference between nitric oxide and placebo, no real effect on troponins. We did get nitrates into the bloodstream, so we successfully delivered drug. And then when we looked at a post hoc analysis, this is one where, like when you do a clinical trial, you got to register and hold up your hand and say, I promise this is the thing that I'm going to study. And you register it on clinicaltrials.gov. That's a government website. This was not something I registered, it was something that I did after the fact. And this was, instead of looking at the comparison between the echoes at 24 hours for those that got placebo to those that got nitric oxide, I compared the change in echo from enrollment to 24 hours to see if you got nitric oxide, were you more likely to get a better right ventricle if it was bad to start with. And if we look at those what are called paired echoes at baseline, and this is enrollment with nitric oxide, 18%, or I'll put it the other way, 82% had something wrong with the right ventricle at enrollment. And with placebo, that number was about the same, 83% had something wrong with their ventricle. Now come back 24 hours later, only 79%, or 79% of patients had an abnormal RV in the placebo group, and now 50% normal. So we got a little bit of signal here, but not enough to really say, wow, this is awesome. And so this is work that's in peer review now. It's not published yet. So we found maybe kind of a modest effect of inhaled nitric oxide, but I want more than that. So we found that it was well tolerated and it had some mild effect. Now, why might it not have worked? I'm going to get into a little bit of biochemistry here, but I'll try to do it as light as I can, okay? Nitric oxide affects the guanylate cyclase enzyme, but it only affects it if the enzyme is in its normal form, and that is with heme inside the pocket. It's a heme-containing enzyme. If it gets oxidized, And remember my slide from the platelets, that there's an increase in reactive oxygen species? If it gets oxidized, nitric oxide can't work on guanylate cyclase. In fact, you have to use a different molecule. And the one that will work is something called senesigwat. Senesigwat over on the left will work on the sick version of the enzyme. There's also a stimulator that will work on the happy version of the enzyme called ritasigwat. Ritasigwat actually now has FDA clearance to treat CTEPH, but nothing has been used to treat acute PE or to treat the CTED, chronic thromboembolic disease that I mentioned. So my hypothesis is that one of the reasons that nitric oxide didn't work as well as I would like is there was a bunch of enzyme in the lungs and in the platelets that was oxidized and unresponsive. So let's go back to the rat and see if we can solve this problem a little bit, because I can't solve it all in people. I can't like experimentally oxidize your guanylate cyclase and see if nitric oxide works or not, but I can do it in rats. So let's go back and look at a basic observation. Remember I mentioned that I clog up rats' lungs with plastic beads. And when I do that, for the first day or so, the rats get a big increase in their pulmonary arterial pressures, the right-sided pressures, as shown by this curve up here. So the first day, the pressures will go up to about 50. But then what we notice time and again is that the rats would normalize their pressure over time. And that scarred off right ventricle would recover to some extent. They could normalize their pressures. And we sort of thought there could be one reason. Maybe they just have frank RV failure. The RV can't pump, so you have low pressures. Well, it turns out it's really not that. The rats are running. They're fine. They're happy. The RV's working again. It just recovers because they're rats. They're indestructible. You know why they're indestructible? Look at what they do. This is a high-resolution CT scan that shows an animal that has not received any beads, and we just injected this animal full of a barium compound and did a high-res CT scan and 3D recon. Look over on the left, you see these big main trunks, and you see some fluffiness, some small vessels, but not much. And these aren't photoshopped or anything. This is PE. This is what happens 3 weeks after you inject beads into a rat's lung. They develop a ton of new vessels, like, I mean, threefold the number they had before. They're unbelievable animals. They said, hey, you clot off 75% of my blood vessels? Screw you, I'll make 3 times as many more. So that's what they do. And they decompress their right ventricle. So what we had to do is say, well, how are they doing that? What is the mechanism? And whenever you talk about new vessel growth, you always got to think about VEGF, vascular endothelial growth factor. So we went in and blocked VEGF using something called Sugen in the animals that had plastic beads in their lungs. And what we found is we could produce CTEPH. Reliably, these animals would get increases in their pressure. And here's some data to show that. And these are 4 groups here. Sham, they got just the operation. Sugen only, PE plus Sugen. Look at those RV systolic pressures up in the 60s. That's some severe, Dr. Aziz could tell us, that's some severe pulmonary hypertension in a patient, and it's also severe in the rat. And there it is at 3 weeks, and there it is at 4 weeks. And then this is an animal on the right-hand side that has a telemetric probe in it. This is something that's kind of unique to our group, as we implant probes in the rats, put catheters in the heart and in the lungs, and the animal can run around freely, exercise, and we can measure these pressures. And this is a daily pressure done from telemetry, where you can see the RV pressure in the open circles going up to almost like systemic pressures, like 100. So we get really high pressures when you give beads plus VEGF. And not surprisingly, these rats cannot exercise. This is VO2 max from a treadmill test at 3 days post and then 3 weeks post. So their exercise capacity declines just like it does in human beings who get this disease. And their platelets are hyperactive, shown by release of P-selectin, and also the mitochondrial studies, again, look like they do in the patients. So we've got a picture of high pressures, platelet activation, kind of made the rat look like a person. And that's important to me to solve the problem, is to have a clinically relevant animal model. So I mentioned this loss of vasculature, and here's some quantitative data for it, just to show how much, I mentioned the gain in vasculature that the rat normally gets with PE. Look down there with the PE plus Sugen. You see almost no regeneration of vasculature. And that's with VEGF antagonists called Sugen. And there are some data to show the reduction in the vascular volume on this CT scan. So now the question is, let's peel the onion a little bit more and figure out what is it about the VEGF antagonism itself that's preventing vessel growth? I mean, that's a receptor up in the cell wall. I want to get down and peel the onion more and learn a little bit more. So one of the first things to ask was, well, do these animals just have lower guanylate cyclase activity in the lung? And it turns out that they do. This is an enzyme assay that looks for the development of guanylate cyclase in tissue homogenates. And then mono is a super nitric oxide stimulator. It delivers tons and tons of nitric oxide to the enzyme. And you can see the PE plus Sugen animals have a reduction in total activity of enzyme in the blood, in the lungs. First thing to park away. The second thing is to think, what does VEGF work through? What is its signaling pathway? Well, one of the important pathways VEGF works through is this thing called extracellular receptor kinase. There's two of them, a 1 and a 2, and they're pretty similar in their actions. And what they're designed to do is take signals from the cell surface and turn them into nuclear signals for transcription, and also phosphorylating a number of proteins, importantly, some of those involved in glycolysis. So just by doing reading, I said, I bet ERK is a likely target to go after to figure out that it is the thing that VEGF is preventing that then is preventing the growth of the vessels. If I find that out, then I can discover a more precise thing to activate to be able to grow new vessels in humans. So that's the sort of translational importance. If I can understand ERK, I can agonize ERK. There are plenty of things that will activate it. There's companies out there doing high throughput screening to activate ERK. You got to be careful though, because it can be part of driving certain cancers. So you want to be selective about where you give it. And remember, the lung's pretty cool because we can give inhaled therapies that remain almost only in the lung, so we're not going to drive somebody's prostate cancer that way. So the ongoing hypothesis of our work is that pulmonary hypertension after pulmonary embolism caused by VEGF blockade can be prevented by soluble guanylate cyclase activation by way of the ERK1/2 signaling in the lung. And this is just a cartoon to remind, if you've never seen ERK signaling, of what it does. There's an agonist at the cell wall, that circular thing. Goes through a couple of different enzymes, ultimately phosphorylates ERK and makes it active. Then ERK goes on and does other things. It affects the nucleus, and importantly, it goes down and it phosphorylates an enzyme that's the gatekeeper. Okay, who's studying for step 1? Anybody studying for step 1? Okay, what's the key regulatory pathway in glycolysis?
Key regulatory pathway?
The entry point. What's the entry point to glycolysis? What's the main controlling enzyme? PFK. Now, glucose 6-phosphate or glucose 6 kinase is probably the right answer on the test, but PFK is really the thing that controls the activity. Now, PFK controls glycolytic activity. Endothelial cells cannot make new vessels unless glycolysis is really activated in the endothelial cells. So that's actually how cancer cells work. They have there's something called the Warburg effect, where the endothelial cells become active over the glycolytic, and they form new vasculature for the cancer to grow in. Well, I want to leverage that effect in a good way in the blood, in the lungs of human beings with clots by activating ERK, which phosphorylates this key regulator, phosphofructokinase fructose bisphosphate. This is an enzyme that in turn increases fructose 2,6 bisphosphate that then activates glycolysis. Bottom line is, I think guanylate cyclase activation and increase in guanosine monophosphate increases glycolysis, and we have evidence of that, and then in turn stimulates angiogenesis. So I have to tell that to you qualitatively because I only have an hour to talk and I don't want to go on and on about things, but that's the basic mechanism by which I think that the ERK1 works. And so this is an overview of the experimental diagram in my R01 of what we're doing, which is first of all just showing that if you give PE, you get an increase in phospho-ERK, which is the active form of ERK, and you get a bunch of new blood vessels. If you block VEGF, you get a decrease in phospho-ERK, that's the activated ERK. Now you don't have any activated ERK, and you get attenuation of vessels, and you get pulmonary hypertension. Now, if we come in and stimulate guanylate cyclase or activate it with sinusiglot, that's the one that works on the diseased form of the enzyme, we can restore phospho-ERK and get new vessel growth. So we can overcome the VEGF antagonism and perhaps stimulate growth of vessels in human beings. Now you might say, well, look, Kline, Sena's cool. That works on the oxidized form. You've kind of shown some evidence that maybe there's a signal for that in platelets, but there's no way you're going to get smooth muscle out of human lungs and measure this. So we don't know for sure that that's right, but at least I can take my rat lungs and grind them up, and I can find out is sinosiguat more potent than riociguat. Now, why do I care about that? Because riociguat's cleared by the FDA. It's out there. It's a drug that I could use right now. I mean, I could get an IND, investigational new drug from the FDA, and I could study it. Sinosiguat is not yet cleared by FDA. So I want to find out which one is best, and this is some evidence that shows me that Sina is probably better than Rio. And this is a dose-response curve that shows cyclic GMP production on the log axis, and that's again using that enzyme assay. The bottom line is Sina is hundreds of fold more potent per milligram of protein than is riociguat. So what I'm worried about is you got to give too much Rio to get pulmonary vasodilation and platelet quiescence, and we'll get hypotension with Rio, and that's what in fact we've seen in the rats. So some evidence that Sina is a little bit better. And in fact, when we give Sina during the period after the VEGF antagonism with Sugen, we do restore normal pressures. This is a curve of a couple of different rats that are exercising. The first thing I'll turn, going from bottom to top, if you look at baseline PE plus Sugen, this is an animal that's exercising, and of course the pressures go up on the right-hand side, but his pressures go from 40, and that's what they are walking around when an animal's doing a little bit of exercise, up to about 60. Okay? Now we go up to the very top, and if you see those curves, these are animals that have CTEPH with my VEGF antagonism. When they exercise, their pressures go up to systemic pressures, like the same pressure that you should have in your brachial artery. And in fact, their RV starts to fail. It cannot even generate any more pressure. So those at the top are the guys that did not get any Sina. And down at the bottom is what happens when we give Sina. And we only have to give Sina for about a week and a half to block this effect. These rats are now off of the Sina. They're not on it anymore. And the reason is they've generated new vessels. And they can exercise and they can kick some ass on the treadmill. And here's some high-res images that show sham, PE plus Sugen, and then there you can see the increase in vasculature with the PE plus Sugen plus Sina. Now it's not quite as robust or the same as it is in the native PE, but you can see a visual difference, and there's a quantitative difference in the amount of vessels that are in the lung. And at the same time, when we measure the pressures, this is just a more sophisticated measurement of RV pressure in a larger number of animals. The PE plus Sugen plus Sina, and again, the Sina is only given for about a week and a half. We can completely normalize the RV pressures. And then this is some RT-PCR data showing gene expression of of both ERK and of the guanylate cyclase subunits. And it's pretty cool to me that Sina increases the transcription of both the two different ERK isoforms as well as both subunits of the guanylate cyclase. And that's shown here. This is the treatment arm. And in each case, you get an increase, and I should have some asterisks on there. Now with PE alone, you get a bigger increase, but we almost act like PE without Sugen when you give Sina. So Sina is help restoring, or we like to say overcome, the VEGF antagonism. And I believe will help overcome pulmonary hypertension in patients with the CTEPH syndrome. And then some Western data show again that the Sina increases both phospho-ERK as well as a platelet-derived growth factor receptor, which is part of stimulating new vessel growth. It also normalizes the platelets, makes them happy, reduces their oxygen consumption, P-selectin release, and their microparticle formation, which is part of that diagram I showed. And remember those diagrams I was showing you of the calcium fluorophore, the green platelets? We measured calcium. This is some platelets from patients with PE who have received sinosiguat. And you can see what happens with thrombin generation, thrombin stimulation to the cytosolic calcium concentration. With only 0.1 micromolar of sinosiguat, you can have a significant decrease in the thrombin-stimulated calcium concentration, and at 1 micromolar, a pretty good drop, and that's down even below what healthy patients have. So with low concentrations of senna, we can normalize that hyperreactiveness, that twitchiness of the platelets. And in comparison, this is a PAR antagonist, a thrombin antagonist, and this is a platelet activating factor antagonist. So these are just shown for comparison. These are like the best thing that we have right now to calm platelets down in the therapeutic world. Nobody right now is using senna to calm down platelets, and you can see some evidence here that senna is going to give us two things. It's going to help the lung, and it's going to help the platelets by reducing that calcium signaling. So the next step, and this is going to happen, is if you want to study a drug, I'm not going to start a drug company. I've got to go to a drug company that can make the drug. So I've been working with Bayer, big giant German company, for over a year to try to get a trial going. And I wanted to get a trial going of a sinusigwat-like molecule that acts very much the same as sinusigwat. But the company, being a company, wants to do the thing that is most likely to make them money. And what's most likely to make them money is to use a drug that's already gone through the FDA clearance procedure. Now remember, I don't want to use Rio, I want to use senna, and I've told you the reasons why, but you don't always get what you want. Sometimes it's a negotiation. So we're going to start a trial of Rio-sigwat in CTED. I think it'll give us some partial effect, but I don't think it'll give us quite what we want. But it's another step toward what I would like to see happen is in the next 10 years, when you treat a pulmonary embolism patient, you'll start hearing about, oh yeah, we need to start a guanosine monophosphate signaling drug. And it may be senna or something like it. It may possibly even be a phosphodiesterase inhibitor like Viagra. But I think you will see it become part of our armamentarium. And it's something that I'm trying to help contribute to as a new treatment that doesn't increase the bleeding in the head, attenuates the pulmonary hypertension, calms the platelets, reduces the risk of recurrence of clot. So in summary, emergency care can accommodate a whole bunch of interests. Now you don't start off being all over the place. You got to start off being focused to get your grants. But ultimately the cool thing about emergency care is there are a lot of forces that make you want to study interesting and fun things. From a cellular standpoint, I think the only thing I want you to remember is if you increase cyclic GMP, it equals cellular relaxation, both in the platelet and in the lung. Inhaled nitric oxide, you know, when you're on your ICU rotation, you see a really bad PE. I wouldn't be surprised if somebody wants to use some inhaled nitric oxide, but I don't think I should haul down the machine and give it to every patient with PE. Maybe a few of the really severe ones. Cyclic GMP in the rat can definitely overcome PE plus VEGF and prevent the development of this CTEPH phenomenon. So that's my summary of work, and I have to, of course, give the usual side of the people who do all the work. And just want to, you don't know these people, but you just got to sit through this slide. This is what you always have to do in the talks because this is like, you know, getting the award or whatever. This guy up there at the top is John Watts. He's a PhD I worked with for many years. And he actually came to visit me in Indianapolis. He got pictures from last week. You see me holding on to John there because I miss him so much. But he's retired and he's really enjoying retirement. And so he's the second person in the last week that's told me he's really enjoying retirement. So maybe it's something that we could all look forward to one day. Down here is our current lab team. The lab team is relatively small with Nate Al's a PhD engineer I work with, and John Zagorski, the white-haired man. That's John smiling broadly, by the way. That's John's biggest smile that he could offer. He's a PhD scientist I work with, and Karen Zujan, who's my lab tech. And then Jonathan is the guy that did the platelet work. I remember you mentioned Jonathan's going to inject the thrombin on the platelets. Jonathan Pike is now a first-year intern in our residency program, and he took a year off of medical school to do the calcium work and the platelets with me. So I've worked with a number of med students. They spend a year with me in lab. They get a master's degree, and everybody gets a publication. So because I don't have a program like you have at med school, I just create it and just give them. But they have to take a year off. They give a salary. The CTSI gives them, you know, $25,000 or something like that to do it, but they have to take another year at work. And so Jonathan did some great work. And just to kind of tell you that the system can work, I mean, we're already teeing Jonathan up for faculty. Like, we're going to reserve a spot for him because we want to keep him. And it has to do with having this differentiator of having that research experience. So I think what you're doing here is a valuable experience for that. Now, this big giant group of people over here on the right is, I think it's about 18 people, counting myself. That's the clinical research side. So this would be typical of a clinical department, kind of relatively small basic science group and a huge clinical research group. So these are the folks that help carry out the INOPE study and some of the other clinical trial work that we're doing. Last slide I want to show you is just, you never forget the people that brought you up. This is another slide of faculty member from Virginia Tech. I saw him last year. It's Dave Bevan in biochemistry. He gave me my first undergraduate experience. He taught me to love doing research because he was such a great guy and just the way he treated me. And I was with my wife Judy walking around campus last summer, and I just sort of said, I wonder if I can find Dave Bevan. And just sort of went up to biochemistry, walked around, and he was in his office, and I found him, got this picture of him, and he retired the next month. So I caught him right before he retired. So a lot of retirement going on. But Dave Bevan meant a lot to me, and so mentoring is such a key part, and it's something that you never forget. So that's it. I wanted to leave a little bit of time to talk. We've got 10 minutes, so I'm interested to hear your point of view and questions, and what should I be doing better?
Okay, thank you very much. We've got time for some questions or comments. Floor is open. About it.
Thank you, Dr. Kline. It was a great talk. Not my field, so I have a pretty general question, but do we know for sure that stimulating new vessel growth in humans would be an answer to pulmonary thrombosis?
Absolutely not. We don't know for sure. Those vessels work in the rats. They don't increase shunt. I can tell you if you sit next to somebody who sees a lot of CTEPH patients or patients with pulmonary hypertension in general, one thing that you will learn or see is collaterals sustain their life. They will say, if you get collateralization, you can overcome these pressures. So the patients that are able to do it now, naturally, with whatever genotype they have, do better, have better 6-minute walk tests, and you can see the collateralization on CT scan. So there's some indirect evidence. But you are right. I mean, maybe we'll make more vessel growth in tumor cells or some other off-target thing. That's the risk.
I have 2 questions, but the first one, was there any pushback or concern from Bayer for the Rio Sabot trial after it shut down for the group 3 trial?
Yeah, it's Senna.
Oh, Senna.
Yeah, it's Senna. Yeah, Senna. Well, remember, that was the highest dose of Senna. It was way above what I think will work in terms of a concentration. So yeah, that's the big thing that's holding Bayer back, besides the fact that they already have FDA clearance for Rio. That's the other pushback I get. It can be given inhaled. That's the big difference, and I didn't get into all of that. We don't necessarily have to give it by pill or give it by drug. We can inhale it, keep it in the lung, minimize the systemic effects. That's great. You know too much. So this is a plant here. You're ready to kill me, aren't you?
Is there any talk of using Senna with any of the other groups?
What would you do? What would you do?
Try. I mean, it's not for PAH, so maybe using Senna for group 1, 2.
Yeah, use something else. Maybe use both Rio and Senna, and hit both enzymes. And so we're going to do that in the rat and see if we can use the lowest possible dose IV and reduce any systemic effects. Great idea. You should come work in my lab.
Yeah. When you were treating the human platelets with Senna to sort of calm their behavior and reduce their sensitivity, did you check to see if the metabolic derangement of the mitochondria that you saw in the pulmonary and in some cases was rescued after treatment?
Yeah, if we put them in the Ouroboros, it normalizes.
Okay.
Yeah, I just didn't show. I did too much data. I took a bunch of slides out because I knew it was going to get too much data. But yes, it normalized the oxygen consumption.
Jeff, great talk. I just want to emphasize a few things. One of them is what you have touched base of. Now our understanding of pulmonary hypertension over the last 10 years, the glycolytic shift. We're talking about a tumor of the pulmonary artery versus just a simple constriction in the pulmonary artery that was along with the incited thrombosis and remodeling. The other thing is when you look at the patient who's been exposed, or I guess that was a rat, for nitric oxide, and they did not respond a little bit, but you did not see the same effect as you saw with Risoport and Senna. I guess the issue is, do we think those kind of model, they are deficient in nitric oxide and this is the reason we're trying to replete it? Or the problem is they have too much nitric oxide, yet they're resistant. No matter what you give, they're not going to respond. And this is the reason why Rasuplot and Senna, they're working a different pathway. They're bypassing the nitric oxide already. They're working at a lower level. You think that's the reason we did not see the same response?
There's lots of reasons nitric oxide could have failed. One is oxidation. The other is dimethylarginines, which inhibit nitric oxide synthase as well. Giving exogenous nitric oxide should be able to overcome that, but there's other things that can modify guanylate cyclase in terms of thiol oxidation, phosphorylation. There could have been other PTMs. Multiple reasons.
If I could maybe just follow up on a little bit, just for a second, ask a quick question. So if you're looking at coupled oxidative phosphorylation, you're producing reactive oxygen species like superoxide anion, and then you're going to have a combination and get peroxynitrite to accept nitric oxide. It seems to me you're going to be diverting away from your NO effect on the soluble guanylyl cyclase. So is there anything to be said for interfering with superoxide anion production concomitantly to enhance effect, or can that be done?
Yeah. All right, so in fact, believe it or not, in my consent form, I had a line in there that was in patient language about the possibility that we might form peroxynitrite and even damage your lungs. One of the ways that I wanted to measure that was with exhaled condensate and measure the peroxynitrite in the vapor that comes out of the lung. We ended up never doing that. I think the answer is right. So basically just acute, like superoxide destruction of the nitric oxide and trading off superoxide for peroxynitrite, which is just as bad, maybe even worse. And that could have been part of the problem. So it makes you raise the question, should we be pre-treating with Tempol or an antioxidant effect? So that,
Interestingly, just as a comment, in the central nervous system, we have an interaction effect where peroxynitrite interacts with voltage-gated calcium channels to affect activity in synapses in the central nervous system. It just got me wondering whether there's some ion channel modulation going on vis-a-vis either directly the nitric oxide itself and or the peroxynitrite production that might be happening. Is that part of your model in any way, shape, or form?
I think I need to do a postdoc in patch clamp technique to do that.
We got it set up for next year. That'd be great. I think with John working out right. I'm sorry, question up here.
Yeah, so I have a more clinically oriented question, but we're first year medical students, so it might be a naive clinical question.
We're the best.
So, in the setting of weighing the risks of arrhythmia against anticoagulation, we might use like a CHA2DS2-VASc criteria to try to decide whether or not it's worthwhile or safe. The benefits outweigh the risks for using that anticoagulant. Is there a similar type metric for pulmonary embolism, or is it just up to your clinical judgment? Could you expand on that for a second?
Yeah, so you're talking about atrial fibrillation and the use of CHA2DS2-VASc versus the HAS-BLED score and making a decision about whether you're going to bleed or whether you're going to prevent stroke. That's prophylaxis, and of course is different than the treatment of an active clot. So it's a little bit of a different calculus that we're looking at. Now I think the question where that really becomes relevant is usually we treat you for 3 to 6 months for blood clots in the leg or lung, although we're learning more and more that it's probably better to treat pulmonary embolism for longer periods of time. The recommendations right now are lifelong if you're a male, lifelong if you're a male for pulmonary embolism. A lot of people don't want that. So now we're looking at similar scoring systems. They've got names, DASH, Vienna, and HER2, and we're trying to figure out which of those scores make it so we should continue anticoagulation, just like you're suggesting with the CHA2DS2-VASc for AFib. So we're behind AFib in the VTE world. We're trying to catch up to all the cardiologists with their work with coronary artery disease and AFib, but we're behind.
But ideally, you'd like to not have to worry about having someone's brain bleed.
I really believe that we will get enough benefit from Senna that some people can come off anticoagulation earlier and have less duration of exposure. You can already get some benefit with aspirin, but I think you'll get more with Senna.
Any other questions? Yes.
Just a quick question. I know you said that one of your big concerns for thrombolysis is bleeding, intracranial bleeds. In your center, are you using catheter-directed therapy? You look at the series of the Seattle 2 data.
Sure.
150 patients. They all bleeds. 150% of patients.
Sure.
What do you comment on that?
Okay, let's move it forward and look at the 2 meta-analyses that now exist of the 950 patients that are in the literature using catheter-directed lysis. All of them happen to be with the ECOS system. The bleed rate is 0.5%, the head bleed rate in that meta-analysis. So it's not as low as it was in Seattle. Remember, Seattle had a 17% of moderate or severe bleeding, but no head bleeds. So it's not perfect. What do we do in our group? I started the level 1 treatment, level 1 PE program, and we send more patients for catheter-directed lysis, about 3-to-1 for catheter-directed lysis compared to systemic. And why? It's emotional response. Why is it an emotional response? Because if I bleed your head with a catheter in a clot, I gave you 1 milligram per hour of alteplase versus 100 milligrams given IV. So I feel like I did everything I could to prevent the bleed, but we don't have any proof that that's actually the case. And I just gave the meta-analysis data, which are really not that different from systemic bleed, head bleed rate. But what am I doing? I'm still sitting up to a catheter-directed lysis because I feel like I'm doing something to try to prevent the effect. Because when you do that and the nurse calls you and says room 6 is seizing, it affects you and scars you for life. And you got to recognize that we're human beings. And when you feel like you did that, you never want to do it again.
Great. Please join me in thanking Dr. Kline again.